and this is Baptist Health Facebook Live. May is National Stroke Awareness Month, and according to the National Stroke Association, during this month alone, some 65,000 of our fellow Americans are going to be experiencing a stroke. And stroke here is the fifth leading cause of death in the U.S. So there's a lot to talk about. We're going to have a discussion and we want to answer your questions. So if you have a question, please go ahead and type it into the comments box on your Facebook page, and our experts will answer as many as we can in the time allowed. And speaking of experts, let me introduce them. First, we have to my right neurologist Dr. Felipe De Los Rios, who is the Stroke Program Medical Director at Baptist Health Neuroscience Center. And also with us is Daniel Damore, RN, who's the Stroke Program Manager at Baptist Health Neuroscience Center. Thank you guys so much for coming today.
Thanks for having us.
Yeah, thanks.
It's a big topic. There's a lot to cover, but let's go ahead and start with the basics. Dr. De Los Rios, what is happening in someone's brain when they're having a stroke?
Yes, so that's the basic question, right? What is it and what does it mean? And generally, a stroke happens when there's lack of blood flow to an area of the brain. So the brain basically starts to stop functioning because you're not getting the energy, the brain cells are not getting the energy to function. And you lose whatever that area is supposed to be doing. So everything we do is we're able to do it because of the brain. So normally things like talking, just understanding language, vision, all of that is through the brain. So whenever that area stops working, then you lose that. So you might have weakness of an arm, weakness of a leg, difficulty speaking, not seeing very well, not feeling very well, and it usually starts abruptly. So you're fine, and then all of a sudden you're not fine.
Wow. Let's talk about how many people are affected. Is it equally common in men and women, and are there any minority groups that are particularly affected?
So women actually have a little bit higher incidence, but one of those things that you really can't pinpoint is why is that so? A lot of people think simply because women live longer, right? So because they live longer, they're going to have a higher chance of having a stroke throughout the lifetime, because the stroke is very much age related, although you can have a stroke at any age. The older you get, the more chance you have of anything, right? Heart attack, stroke, diabetes, anything with age.
Well, speaking of age, that's a good point, because in the news recently there have been a couple of very high-profile stories in connection with the deaths of some younger people with stroke. Luke Perry, who is only 52 years old, passed away after a stroke, and then 51-year-old director John Singleton. To me, that seems very young to be having a stroke. Is this a trend, and why might it be happening?
So, just like Daniel was saying, a stroke tends to happen as we age. You know, there's wear and tear on all our bodies, including the arteries, and you accumulate some of that injury damage to the arteries as time goes by, especially if you have some of the risk factors like hypertension, diabetes, and things we can talk a little bit more as the program develops. But about 10% of strokes happen in adults younger than 50.
10%?
About 10%.
Wow.
Yes, and we've actually seen that it's increasing. So when we look at hospital admission data and some incidence data from population-based studies, it seems like over the last decade or so, it might have even doubled.
That is significant.
Yes.
And are we talking about, you talked about risk factors of hypertension. Are we talking about other risk factors that are lifestyle related?
Now, one of my favorite ones is to talk about activity. So
okay.
as we progress through the generations, I think it's pretty clear that our activity level is way less than it was 20, 30 years ago. I'm also in my 50s, and I can remember growing up always being outside and chasing dogs and throwing baseballs and all that kind of stuff. And I don't think that that's quite as common today. I think we've gone away from playing outside. Schools have reduced recess time. All those kinds of things that really is one of the most important thing is activity. The more active we are, the more engaged we are in physical fitness and all that kind of stuff. Obviously, that's going to reduce your risk as opposed to increasing your risk. So I think there's definitely something that plays a part there.
Yeah, we think that's one of the key drivers. We don't know for sure, but it does seem, and some of these studies have also shown that we see the risk factors for stroke and heart attack, which are very similar, happen earlier in life, and then it being less controlled. So that might have to do something with it. There's also a relationship within substance abuse as well and stroke, and that's something that the societies have been battling with, and we have epidemics of like, opioid crisis, and there's drugs like cocaine and amphetamines and things like that. And even some other medications or drugs that you wouldn't necessarily intuitively think that could be related to stroke, like for example, some weight loss medications, things like that. It can also increase the risk of stroke.
Fat burners and things that we're thinking, to increase your metabolism, things like that.
Right.
They increase your metabolism, but they also increase a lot of other things.
Yes, so it might be multiple things that are related to that.
Well, you were talking about kind of illicit, illegal drugs.
Right.
But what about kind of the everyday drugs that, fortunately, a lot of Americans use, alcohol and tobacco? What are their effects on stroke?
So smoking, as we know, is not only a risk for stroke; it's also a heart attack. And what it does is it plays a really bad part on the viscosity of the blood, of your blood itself, how available your arteries are to expand and contract like they're supposed to do to have equilibrium. So those things, it's kind of like beating up your arteries from the inside out.
And is that what high blood pressure is doing too?
Absolutely.
I mean, it to me, it doesn't seem, it's hard to visualize. How do you visualize what high blood pressure is doing to your arteries?
And that's part of the problem, because high blood pressure, especially during the early phases, doesn't cause much symptoms. So people can live a long time with their blood pressure being high and not realizing, unless you go for your regular medical checkups.
Yeah, we've heard that called the silent killer. That's exactly why.
Exactly why,
Okay.
yes. And it's like having, a very simple analogy, but it's like having the pressure high on your house, and then, pipes start bursting and things, start not working as there's more wear and tear on those conduits over time. So it's kind of, in a simple way, what happens in the body. The high blood pressure does more wear and tear. It predisposes the arteries to either block off the smaller ones or develop fat buildup on them as well. And then that generates problems. So, and this goes back to what you can do. But in general, if you're able to control those risk factors when you're young adult, middle age, you definitely have a much healthier later life. So it's never too late to start, but it definitely, I think you benefit the most when you control it.
When you do it from a young age. And
Right.
young people are probably less likely to go to the doctor.
Right, because you feel well.
Yeah,
right? Yeah.
exactly. What about some of the more obvious comorbidities, diabetes and things like
Obesity.
that? Obesity.
Again, leads directly to inactivity. That inactivity leads to obesity. Obesity leads to diabetes. So we have a lot of things that are kind of beating up on each other. Our body's really meant to work in pretty tight tolerances. And when we exceed those tolerances or we ignore them, things start to go wrong, right?
So do you have kind of the basic, 3 or 4 things people should be knowing and aware of when they're young to try to avoid problems later on with stroke?
Yeah, so many I think we've already kind of touched upon. The American Heart Association has a list of 7 healthy habits. But in general are things like we said, minimizing your alcohol intake. Really, any amount of alcohol will increase your risk of hemorrhage, as well as the risk of cancer, actually.
Has a blood thinning effect.
Now, for ischemic strokes or that were a blood clots, you have to drink more regularly to do that. So I think it's about 2 drinks daily for women and 3 for men. So the risk of ischemic stroke, you have to drink a little bit more, but really for the other health hazards, any amount of it is increased by alcohol. But anyway, so decrease risk of alcohol, avoid tobacco, diet and exercise.
To me, huge, right? Especially
Yes.
getting the younger generation to understand that that's going to have a long-lasting effect.
Absolutely.
Right, it isn't
Right.
just something
It's
that
not
they can
something-
get
and you
away with
Right.
forever and
you
then
can't
take
fix
care of
overnight
later.
either. So
Yeah,
we know
and
when we
that's-
go,
no
how many
kidding.
times do we look at ourselves when we go too long without exercising and then we
Yes.
kind of regret it later? Well,
Yes.
so that's the whole idea. So avoid the long periods of inactivity.
Yeah. And for it to really work, you have to do 3-4 times per week. And
Not
you can't
just
build it in a
one
day
to
or
the
two.
gym,
No,
right.
you can't.
And getting
It
your
has to
heart
be
rate up
regular.
each and every time.
Right, right. It has to be at least moderate intensity, and it has to be regular exercise. So weekend warriors just get joint wear and tear. Really,
They end up
You
going
don't-
to our doctor's hospital
Yeah,
with
our
the
orthopedics.
yeah, our orthopedics.
right. You don't get that vascular benefit, but
Right.
that, and then making sure that you check your blood pressure. So you have to get that checked. Make sure that you get screened for diabetes. You have to have your glucose checked. So you have to go to the office for that. Your cholesterol, I'm sure your cholesterol is in check as well.
Okay.
I will add something about high blood pressure, and this is something that we don't always consider, and that is that the compliance of your arteries are going to they're going to get worse and worse as you age, even with the same level of activity, same diet, same exercise regimen. It's part of the aging process. So if we don't really stay on top of that, it really has a downhill effect, right? So
Yeah.
we really have to be aware of it.
It's one of the few interventions that we know that also might decrease the risk of dementia.
Really?
Yeah, exercise, regular
so
exercise.
exercise, and I've heard your mood and mental health also
Absolutely.
is
Well,
related.
and that's one of those things we don't always talk about either, is one of the big risk factors is stress. Stress is a big risk factor for everything cardiovascular. Again, heart attack. So going back to that, we like to link heart attack and brain attack. So sometimes we call stroke brain attack
Okay.
for that reason, so that you get the idea that your organ, the brain, is undergoing the same attack as your heart would be by getting that oxygen supply cut off. So it's kind of a good way to make that link between heart and brain.
That's a good description. That really puts a mental picture in your brain
Right.
of having a brain attack, which is scary. But let's talk about how you recognize in either yourself or someone around you the symptoms of a stroke. How do you know?
Well, so I always start by saying, especially when I'm working with community and paramedics and general community, is that you have to remember that it is any acute neurologic deficit that you have, right? So it could be anything. We have to be very aware of a sudden incidence of something debilitating, right? So that could be acute confusion, the inability to speak or understand speech. So there's a lot of different things that are going on. We try to bundle them so that it's easier to digest. FAST is one of those acronyms that we really hammer, right? That's face, arm, speech, time. The face would be any kind of facial droop, especially on one side of the body.
Okay.
Arm would be kind of like arm weakness, and that's often depicted as somebody dropping a cup or something like that. Speech could be the inability to produce speech or the slurring of speech, and that means somebody all of a sudden is looking at you and can't speak.
Oh, gosh.
Versus they are speaking, but what they're speaking is
Isn't
either
making
slurred
sense.
or gibberish, right?
Wow.
And then you've got that T for time, and that is time to call 911.
Okay.
So when we have that fast, what's the percentage of that? It's like 80% of anterior circulation strokes are covered by that FAST acronym. So it is important that we really focus on that, and then recognizing that there could be all kinds of things as well.
Yeah. So, and I will just add to that. In the FAST, there's the A is for arm. I mean, it really is a limb. It could be the leg,
Right,
but
right.
and you only need
it's
one.
especially on one side of the
Yes,
body.
on
Okay.
one side is really what drives the concern for stroke specifically. But you only need one, so you don't need to have the face and the arm and the speech.
Okay.
It could
It
be
isn't
any-
a
If you only
combination.
know,
You just see one.
you just need one of those.
And probably better safe than sorry to be aware and to call
Absolutely,
somebody.
absolutely, because the time, like Daniel was saying, is very, very important. The brain doesn't store energy. That there's no fat cells in the brain.
Okay.
So whenever it's not receiving blood supply, it's not getting any energy, and the brain cells don't survive very long without that energy.
They
So
die at the cellular level. So
Right,
And
that
that's
gives you
not
an idea.
coming back,
Once it's
right?
dead, it's gone.
That is
No,
that is
no, and
frightening,
that's
but
why, yeah.
it makes it doubly
that's why time is very important. We commonly see in the hospital, I felt my arm was weak, but I felt maybe I slept on it or something.
We hear that often.
And
I
I
felt
wanna-
like I
and
fell
then you wanna
asleep on my arm and it
wait.
felt funny,
Right.
thinking that it's going to get better.
thinking it's
Right,
going to get
and you
better
wanna
instead of
wait.
saying, wait a minute,
Right,
that could be a sign of something really serious.
Right.
Right. Exactly.
The time frames that different treatments are effective are important to know about too. I know there is the blood clot busting drug,
Right.
TPA, that can be given in a certain window. And then there's another window for more mechanical processes where you're going in and
And
actually
pulling out a clot.
Right.
Exactly.
How are those effective?
So the first thing to I think hone in is that you shouldn't wait.
Okay.
You shouldn't
No matter
wait.
what, don't wait.
Yeah, so don't
It's
think,
a medical
I have,
emergency.
yeah, I don't have maybe
It's a medical
4
emergency.
hours, 6 hours. Don't think about that. I think
Okay.
if at any point there is a concern that there is a stroke, you need to get to the hospital as fast as possible.
Okay.
And not any hospital. There's specific stroke centers,
Okay.
and there's licensing that goes with it. The state will give some accreditation, and there's some national bodies that would accredit hospitals.
Certification.
Certification, exactly, and EMS knows this very well. So I mean, Daniel can tell us more about that specifically. But the medication can be given up to 4.5 hours from when the symptoms started,
Okay.
or we go by last seen normal time, and the surgery can be done even up to 24 hours or a little bit late. It's not that brain cells survive differently. It's
Okay.
just that if you have a blockage on an artery, on a bigger artery, there's this thing called collateral flow. So imagine if you block US 1, right, and there's a traffic jam, you can get to where you go through the side streets, and that allows some brain tissue to survive longer without being irreversibly injured, because it's getting trickle flow. It's getting a little bit of blood, not enough to function well, but enough not to be irreversibly
You're getting
injured.
to work. You're just getting in there
You're
late.
way late.
Getting way late.
There are consequences.
There
Yeah,
are,
there are.
Saying
yes.
that. Yes.
So as more time goes by, that area then gets more irreversibly injured to a greater extent, and then after a certain time period, you can't do anything about it. But the sooner we're able to intervene, either with the medication or with a surgery, then the higher likelihood of a good outcome. Yeah.
I know you're involved in training first responders.
Yeah, so one of the most important things I do is actually EMS outreach. So that collaboration is kind of like, I think of a stroke center and a stroke program is like rings. The outermost ring is community, right? So we need to get community education out there in the signs and symptoms of stroke, which is exactly what we're doing now, right?
Okay.
The kind of inner one is now pre-hospital. What happens once community calls 911, that inner ring is all in the parameters of paramedics and EMTs. They're the ones that are they're the ones that are assessing the patient, triaging them based on what Dr. De Los Rios was mentioning, is that not all stroke centers are alike. Depending on the kind of stroke, might need to come to a comprehensive stroke center versus a primary stroke center right from the bat because of the way it looked like a bad stroke versus a stroke, right? And then that inner one is the hospital program. So it really is it's like systems of stroke care in rings is the way I like to look at it. So one of the things I actually enjoy most is going out into EMS and helping them with that very difficult assessment of a neuro patient, right? So a neuro
That's
complaint,
asking a
like we
lot.
mentioned before, it really
Yeah.
can be anything.
Yeah.
It can be anything that is neurologically impairing you suddenly, and all of a sudden you have to think, well, it might be a stroke. So given their tools and working with them and helping them to do the things that we want them to be able to help us, so we're helping them to help us, really it's kind of all in the effort to help the patient, right?
Right.
So-
It's all linked together for
Right.
sure. This is great, but I want to start taking some questions from
Yeah.
our viewers. Here's the first one. Are fast symptoms, the ones we were just talking about, are they present in every stroke incident?
Absolutely not. As a matter of fact, I think I touched on it.
Yeah.
But here's another thing: is that the FAST acronym is kind of morphing into we're trying to expand. Picture like throwing a bigger net.
Okay.
We want to cast a bigger net to be able to capture more stroke patients, right? To be able to have more treatment going on. One of the things that we're doing, several agencies are looking at an acronym including the letters B and E, so we would say be fast.
Be fast.
In order to spot a stroke, you have to be fast. It's kind of catchy, right?
It is catchy.
One of the B there would be balance or dizziness. So you can have a lack of balance or a presence of dizziness, and that kind of focuses on the posterior part of your brain as opposed to anterior circulation.
Okay.
And then the E, also posterior, is eyes, because vision is also a very important part of a stroke assessment. You could lose vision in one eye both eyes, it could be blurred vision, so an acute loss of vision is also very important, and that's not even touched in fast,
right?
So by looking at something like BFAST, and also again, my thing is any acute neurologic thing can be anything. I often say this when I teach. If you go into a room and you know the people that you're going into, like in a hospital setting, and you've had a conversation about how you know that their kids are going to go to college and whole kind of thing, and in 30 minutes you walk into the room and they look at you and act like that you've never met before, that's an acute neurologic change that you have to pay attention to. So you got to dig in a little bit deeper, and that's not covered in FAST either.
So yeah, I would add just my 2 cents on that. It's that no scale will capture all stroke symptoms,
Of course.
and there's a balance between complexity and what you can remember, and FAST generally is a much simpler scale, and it captures about 70 to 80%.
80%.
Right.
It loses some of the symptoms, like Daniel was saying, and BFAST captures some of those, but even BFAST will miss some other things.
Right.
So there's no 100% tool. And the key part, I think, is if you can remember fast or be fast, that's great. That's the first
You're on the
step.
right track.
You're on the right track. But then the way we think about it on the physician side, really, is any sudden loss of neurologic function really makes you
Again,
think.
the key is sudden there too, because you can have something that's lingering on for days, and then you come into the ER because this has been going on for days. We know that you're going to be outside of a treatment window. So that's why it's so important to recognize the acuteness of it or suddenness of it.
Loss of balance, loss of vision, loss of sensation, loss of strength, loss of, it's loss off. Loss off.
And that is depending on where that's exactly happening in the brain?
Exactly.
Is that what that comes down to?
If you think about the brain, it's like many, many control centers.
Okay.
So I use my hand often to show cerebral vasculature, right? So these are the arteries in your brain. You could have a clot that travels to an area that only kicks out ability to understand speech.
Right.
So that could be your one sign because
And
that
everything
clot
else is still
so
functioning.
specific
Right.
that it knocked out that control center.
Wow.
Yeah,
So
and
I'd like to
beyond
do it that way.
the acute treatment part, which is what we're focusing on, we're talking mostly about acute treatment, what you can do to prevent permanent damage or minimize permanent damage. But then there's also the things that we do in the hospital, which are trying to sort out why the person had the stroke and how we can decrease that risk of having another one as much as possible.
Is that common for someone who had one stroke to have more?
It increases your risk. If you've had one, then there's something going on
Okay.
that will
That
put
makes
you
sense.
at risk of having another one. So the risk is higher than someone who's never had it,
Okay.
and it depends on what is driving it. So
Carol, I'll throw a number out there.
Sure.
There are almost 800,000 strokes a year. 600,000 of them are first stroke, which means that 200,000 of them are second stroke. So that doesn't tell you that essentially one in four strokes are
a second one. 800,000.
800,000.
That's a lot.
It is a lot.
Next question. What is a mini stroke or TIA?
All right, so I'll tackle that one first.
Okay.
So TIA is transient ischemic attack.
Transient
Ischemic attack.
Okay.
So transient, it means it goes away. So it goes away completely.
Oh.
And
Temporary.
Temporary.
Right?
That's better for the T.
Right. That's right. It's actually transient, but temporary is much easier to understand.
Layman's terms.
And it goes away completely. So it's like there was an area of the brain that wasn't receiving enough blood flow, but your own body has a way of dealing with clots, generally. So for whatever reason, it formed, your body was able to take care of it, and then there was no damage. Right? So it's a warning sign that something's wrong. There's a tendency to either form clots or an artery to block, and then you really need to seek help right away because something needs to be done to decrease that risk.
So don't ignore.
No, definitely do not ignore it. Now, sometimes if the symptoms go away completely, but we do a brain MRI, for example, an image, or you do an exam, and we find that there is an area of damage, then that's not a TIA. That was a small stroke that your body was able to recover rapidly from, but that was an actual stroke.
So there's two different things, the mini stroke and the TIA?
Right. In the TIA, there's no damage
at all.
No damage at all. No, the person goes back 100%, the imaging looks normal.
Looks normal, okay.
Right.
All right.
So what I like to call those is if you have transient or temporary or a mini stroke, I like to consider that you had a lucky stroke because you did have a stroke. You had a stroke that either resolved or you were able to get past it.
Right.
So we have to think of those as it was a stroke.
Exactly.
And if you had one stroke, what are the odds of you having another stroke?
Right.
Pretty high, right? So
Yeah.
you have to pay attention to
For
that.
sure. We have a question about if strokes can be hereditary. Am I prone also because of my race or ethnicity? And I guess that comes back on, we talked about John Singleton earlier.
Right.
African American, is it African American men or is it women or both who seem to have a higher risk?
Right. Both. It's a little bit different between men and women, like Daniel was speaking. In general, women have, during their lifetime, especially the first half or more of their life, they have less risk than men. But because different reasons that are specific to women, but they also live longer, about 4 years on average more than men, and this is very tied to age, then at the end, it's either the same as men or a little higher than men. But you're right, African American men and women have more stroke than non-Hispanic whites during their first years of life. So up to, by first years, I would say up to like late Middle Ages.
Okay.
So like 50s, 60s. And then after that, the difference goes away and it starts to be very similar. And then, so it's African American has the highest, then Hispanic, then non-Hispanic whites at the beginning. And then later in life, they all kind of start to get closer together.
Is that hereditary or is it lifestyle? Do we know?
I don't think we know, but I think you can surmise that there is a little bit of both, right? So I think more importantly is what your individual risk factors are. Again, it all goes back to, are you active? Do you eat well? Do you those kind of things that you can mitigate? You can reduce those risks by being active about it.
For sure.
Yeah, I mean, there likely is some hereditary genetic component to it, but the good news is that 80% of strokes preventable, right? So you're not a victim of your genes in such way. There's a very small group of diseases that are on the rare side that predispose to stroke in a very particular fashion, but the large bulk of it, so 80% of it, is preventable. 80%. So there's lots of things. So if you do have a family history of...
It's very encouraging.
Yeah, of course. I mean, I think you can definitely take control of this. And if you do have a family history of stroke, I think that's a call so that you make sure that early in middle age, or as soon as you can, you start working on lowering your risk factors for stroke, like we mentioned early, to lower it as much as you can. But the bulk of it is preventable.
So when we go to our primary care physicians and they have us fill out those family history forms, is that something that helps doctors kind of key in on that if you've had strokes in your family?
Well, especially if you've had heart attack or stroke, right? Because again, stroke is a cerebrovascular, so it's vascular, it's cerebrovascular disease, right? And cardiovascular disease is the same thing. It's the way your arteries flow through your body and how compliant they are and those things, what you do to take care of them. So I think it's important to, a very thorough family history gives us a better indication of what we're looking at.
Yeah, yeah, and it's not only genes, but it's also location. So within the U.S., for example, we know there's the stroke belt.
We have a stroke belt. We have a stroke belt.
There's a stroke belt, and the southern states, North Carolina, South Carolina, Georgia,
North Florida,
Tennessee,
not Florida, but North Florida,
North Florida, which is kind of more like Georgia than
exactly.
There's a lot more
Alabama.
stroke mortality than the rest of the country. So if you live in those areas, you should also pay particular attention to your stroke risk factors.
Moving away, though, isn't going to just make everything magically happen.
No.
Not if you cook the same way in your kitchen.
Is that what you think it's related to? Is like
I think
the
there's a lot to
diet
that.
There is something around those states, but yeah, I mean it's those states. So if you move out early in life, your risk probably goes down some. But yeah, that's interesting observation.
It is. I had no idea there's a stroke belt.
Yeah,
I've heard of the tornado
There's
belt.
a stroke belt. There's a stroke
belt.
buckle within the belt.
And there's a buckle.
Absolutely.
All right, now I have to know. What's the stroke belt buckle?
Well, I mean, there's just 3 states that have even the highest within the stroke belt.
Centers, right?
Yeah, but it goes back to again to understanding that there's a lot of things that are environmental that could potentially increase your risk of stroke, and whether that be diet, exercise, lifestyle, air pollution, or
Sure,
tobacco.
that's a cultural difference.
Yeah,
in certain areas.
Things like that,
Right.
and you have to a great degree of control over some of those.
That's true.
Right, most
With
of us.
all, it was like, with 80% of strokes being preventable, are they going to put you out of business? Is that?
No,
No?
we'll just work on prevention.
Okay.
That's
Our
right.
business would be
Yeah.
prevention. That would be great. I
Perfect.
would love to do that.
It's a way easier job, I would imagine.
Yeah, I'm sure. So here's another question. What medical conditions increase the risk of having a stroke? We've touched on this a little bit, but is there a list, a definitive list?
Bingo.
Yes, sir.
AFib.
AFib.
Atrial fibrillation.
Okay.
Right? So if you have that medical condition, you're 5 times more likely to have a stroke than someone who doesn't have AFib. AFib is an irregular heartbeat of the top part of your heart.
Okay.
The heart is a 4-chambered pump. You have the 2 top parts are the atria, and then you've got the ventricles.
Okay.
So it's not a gravity flow that goes from the atria into the ventricles to get pumped out to your body. It actually has to pump regularly. Atrial fibrillation is when the top of the heart, instead of pumping like this, is starting to fibrillate. That's why it's called fibrillation.
Okay.
And it's quivering. When it's quivering, the blood that's inside the top part of the heart is pooling. And when it pools, it stagnates. And then all of a sudden you get a pump enough to get through the valve into the ventricle. Ventricle pumps it out as a clot. So there you go. So 5 times more likely if you have atrial fibrillation.
Wow.
So atrial fibrillation is one of those very difficult medical conditions because you can have atrial fibrillation and not even feel it.
And you don't know
Right.
it?
Well, most of
could
it
be.
is
You could
like
not know it.
You could.
2/3 of it is what we call paroxysmal, and many times it's asymptomatic. It's also one of those things that happen as we age. So it's much more common in your 70s, 80s than in your 50s,
Okay.
60s. But the most common, I would say, risk factor is high blood pressure.
Okay.
So high blood pressure, it's one of the most
Which
common
is a
ones.
disease in itself. And that's why we're referring to it
Exactly.
as a condition.
Okay.
Exactly. Diabetes as well. So, I mean, I think those, are probably the most common. High cholesterol, hyperlipidemia. And then when you go talk about risk factors, then tobacco, that's one of the ones that you
Again,
can, it's
changes
so,
the
it's
thickness of your blood.
It's really on
Changes the
our
thickness
control.
of your blood.
Yeah.
Okay.
Well, and it causes the arteries to narrow. It causes arterial damage in
Yeah.
itself. Yeah,
Yeah, you got to take care of those arteries. You
You
only
have
have
to.
so many.
definitely.
It's your plumbing. You got to
It
take
is
care
your
of your
plumbing.
plumbing.
You're right. You're
Yeah.
right. Oh, gosh.
It's much easier to prevent than to fix.
That's
let's
right.
Put it that way.
I'm sure. One more question. When someone is having a stroke, does it make a difference if you drive immediately to a hospital or if you call 911? Good question.
I would love to take this one.
Yes, please.
Because remember that FAST acronym?
Yes, yes.
T is time to call 911.
Right.
There's a reason for that.
Okay.
So over the last 10, 20 years, we've done a lot of work in stroke centers to be able to streamline the process of identifying a patient, get them treatment on time, and number one, to treat them, right? So the risk you run when you drive to a hospital is, number one, you drive to a hospital that's not a stroke center. That could be catastrophic.
Okay.
You go to a stroke center that can't handle your kind of stroke. Remember, we have primary stroke centers that handle a certain percentage, and then you have a comprehensive center that can literally treat anything that stroke presents. You can take care of that patient in the comprehensive center. So there's that. But you have to remember this, an ambulance is like a mobile ER. They get to your house, they establish an assessment, they're looking to stabilize you and to triage you to get to the right place.
Okay.
So by driving yourself to a hospital, and it doesn't matter if that's down the street, you have to remember that that EMS crew is also in contact with the stroke center that it's going to go to.
Sure.
They're getting us ready. That means that we were about to do an elective case in the CT scanner. We say, hold on, pull over to the side. We're waiting for that stroke to come in. So it really bypasses a lot of that front end stuff that you have to deal with in a hospital and goes straight in the back, straight to the treatment area, and then straight to treatment. So it's a huge thing. So going 911, I say every single time.
Every single time.
Every
yeah.
single time.
It is
Okay.
much faster. If you go through triage, there's more layers. You
Alright.
first has to be identified as having a critical condition.
Okay.
And what
By
if you have one of
triage.
those wonky presentations of stroke?
Right.
Okay.
Sometimes it
If
could
you're
be
just a little confused.
Yeah,
sometimes
exactly.
it could be
All of a
more-
sudden,
more
you know,
challenging.
the-
and then
yeah.
and then we get the team gets activated after that. With EMS, like Daniel was saying, you get activated from the field. We know you're coming. The team
We
is
know you're
ready.
coming.
It's much faster.
Yep.
And they know where to
Absolutely.
take you.
That's incredible.
Right.
So tell me a little bit more about the behind the scenes of how you guys are ready to go when you get an alert? How does that work?
So in many counties, including this one in Miami-Dade County, they have, the paramedics use a tool. So that tool is basically a triage tool for stroke. So based on presenting symptoms, based on your last seen normal, based on the medications that you take, it's kind of like a tool to direct them to which stroke center they should go to.
Okay.
Once they've identified, yes, I think this is a stroke, and this looks like a bad stroke based on my tool, needs to go to a comprehensive stroke center, then all of a sudden they give us that heads up. They call in as they're in that patient's house still. I have a 50-year-old male with right-sided weakness, whatever, and then they're telling our ETA is 5 minutes. Well, in that 5 minutes, we're scrambling. The entire ER is really focusing on delivery of that patient so that that patient has a streamlined and very time-efficient process.
So
Does that make sense?
That's what separates stroke centers, right? So stroke centers, and even within stroke centers like Dan was saying, there's primary, comprehensive. Baptist Hospital of Miami is a comprehensive stroke center. South Miami, West Kendall are primary stroke centers from within the Baptist network, and we have specific resources destined to stroke care. So there's a whole team that's ready 24/7. Yes, there's a lot of people. When there's a stroke, there's a lot of people there to make sure that we do things fast. But those resources are available all the time. They just need to be activated for the specific case, but they're available. So when EMS calls, we are available ahead of time right there. If not through triage, then they call us, but it's minutes. It really is. That is available all the time.
It's amazing. I imagine that you have to really, to have all these resources and to qualify as a comprehensive stroke center, it must be very exacting.
Oh,
it's not just like, oh, you kind of have this.
Right.
It's,
No, absolutely.
Yeah.
And ours is a certified comprehensive stroke center, which means that the Joint Commission comes to our facility every 2 years. We really have to prove that we do what we say we do. And that's the most important thing.
Well, we have another question. Well, this is interesting. Do kids have strokes? And do you treat kids having a stroke with that TPA, that clot busting drug?
Yeah, that's an interesting question. So there are strokes that happen perinatally, so around birth, and we know that as cerebral palsy, for example.
Okay.
So that's an early age where there's a higher risk of stroke. And then after that, it really decreases until adulthood. I mean, kids can get strokes. There's some rare
Sickle
diseases.
cell,
Sickle cell can predispose you. There's some diseases of the arteries, childhood arteriopathies that we call them. It's on the rare side. But it happens. It happens. We occasionally see it. TPA is off-label for pediatrics.
Okay.
So in a case-by-case, it might be used just because there is really nothing else besides endovascular surgery, which could potentially be used as well. But thankfully, it's not something very common.
Right.
So the answer is yes, it can happen.
Yes.
And sometimes yes, we can use the TPA, but it's not as straightforward as with the adult population.
So for adults, we don't want to freak people out, but what would they be looking for in their child? Same type of things as the
Exact same
adults,
thing.
just
Absolutely.
confusion, the arm or limb?
It's very similar. They sometimes don't have necessarily the same unilateral presentation, which can make it a little bit challenging. They can have more seizures. Sometimes there's seizures. There can be more confusion and difficulty talking and interacting in a regular way, and things like that. The babies, it's even harder, right? Because then you don't have much to go by, and the physician has to have a high suspicion for it. But for the bulk, I think if you can remember fast or be fast, if you want to be an overachiever, that'll be great. Be fast.
We're going to start educating the whole.
We're all overachievers here, aren't we?
Yeah,
if you remember fast, you're good. If you got be fast, that's fantastic.
That's even, you get a start.
I think that you can identify that, and it's not just you in the sense that when a person is having a stroke, they themselves might not realize they're having a stroke.
Sure, if they're confused.
Well, there's a whole denial part of that too.
Right, so some people might not be
you actually
aware.
be in denial, not like you don't
Right.
want to believe, but you don't believe you're having a stroke.
Right, you don't
Really?
And that's a
realize
syndrome.
it.
Your
Right.
brain
Your
just
brain
tells
has shut
you,
that off.
I'm not
It
having
doesn't-
a
Not having a
stroke.
stroke.
It doesn't realize.
Absolutely.
So that can happen too. So in general, it's good for everyone to know this.
Yes.
And if you have a specific risk factor, so you should definitely make sure that the people around you know as well what to look for and how it presents,
Yeah.
because you would want them to be able to pick that up if that was happening.
For sure.
Yeah.
Let's see, we are getting, I think, closer to the end of our time, but I think we have one more question. Is that right, guys? Maybe one more? Okay. Let me check in with our team. Is it possible to have a stroke while you're sleeping?
Yes.
Yes.
About 30% of the time.
And that makes a very unfortunate, difficult situation for us, establishing the last seen normal. Remember, that's part of the thing. It's kind of like a clock. Think about a clock.
Okay.
When you are able to tell us when the last time you were normal, or even better, when the symptoms started, we call onset. If you know that time, that starts our clock.
Okay.
Now we know we get this much time to get your. We're going to do it as literally as fast as possible, but we know that you're in a treatment window.
Okay.
But if you don't know,
Yeah.
that makes it very difficult.
Yeah, I mean, we sleep, hopefully we get about 8 hours.
At least our 7 hours that we always
What's that,
tell you.
what's
is
that, a
healthy.
third of our day?
Yeah,
A third of our day?
something like that, yeah.
So it happens. It definitely happens. And a stroke generally is not a painful condition, especially
So it's not gonna
lack of
wake
it's
you
Right, it's
up?
usually a
doesn't
loss
wake
of
you up.
something,
It
remember?
doesn't wake
Right.
you up.
A loss of something.
So people realize when they're awake or someone goes up and check on them that things are not right.
Okay.
And for TPA, it has been difficult because we go by the last seen normal. For the strokes that are caused by a larger blockage, then we can offer potentially treatment. And there's technologies evolving constantly, and with some advanced imaging, we might be able to give TPA at least to a group of those people that wake up with stroke, using the image as a witness of when the stroke actually happened.
You can back time a little bit?
You can.
or-
Well,
There's some
it's sort of
imaging
like
things that can show.
rethinking the clock. Instead
Okay.
of it being a clock as in you know when it happened, you're looking at the brain versus you're looking at two things. You're looking at area of infarction or the area that you presume is dead or dying versus the size of the area that will be dead or dying if you don't
If you
treat.
don't, okay.
So we refer to that as a mismatch. If you have a mismatch, meaning that the sizes of those two conditions are different, then
Right,
the
the
conversation
at-risk.
is, well, maybe there is viable tissue to go after and save and give that
So
clot
let's
busting
do that.
medication
Okay.
Right.
based on advanced imaging, which is very exciting for
yeah.
us.
Yeah, so that's what the tissue that's at risk of dying versus the tissue that's already dead, and the tissue that you could potentially save, which is what we call penumbra. So there's that, but then there's also actually using the image to say, well, your stroke happened within the last 4.5 or 6 hours or something like that. So
Okay.
I think this is changing constantly, and
Yeah.
hopefully we'll have more tools in the future. But the short answer is yes, it can definitely
Yes.
happen.
Yes,
Yeah,
it
it
can
can.
happen. Well, this has been wonderful. We are at the end of our time, but I would like to ask if each of you have a final thought that you'd like to share with our audience.
Mine is be active. Just be as active as you possibly can in everything that you do. It's something as simple as park a little bit farther away from where you normally would to go to a grocery store. That's being active.
And even if you feel well, especially if you're young, but in general, just get your regular checkups.
There you go.
Excellent advice. A lot of great information. I've really enjoyed talking about it with you. I hope you guys at home have enjoyed it too. I'd like to remind all of our viewers that our website is another excellent place to get information on healthcare and wellness. You can find us at baptisthealth.net. And please follow us on Facebook. We have a lot of great information that comes on our Facebook page, and we will give you previews of the next Facebook Live events that are coming your way. So on behalf of our panel and everyone at Baptist Health South Florida, I'd like to thank you for watching, participating, and have a wonderful and healthy day.
Thanks,
Thank you.
everybody.
Thank you.